Well, this is wonderful. This is really great. So thank you everyone for joining us today on the SSAT Grand Rounds. I'm Rohan Jeyarajah, and we have the honor of having our fellow Michael Jureller present today on a very interesting and novel topic that I'll let him tell you about. Our moderator today is Ralph A., who is not only the consummate gentleman, but the most amazing surgeon and friend that one could ever ask for, not only surgically, but spiritually too. So Ralph, thank you for joining us. He's sort of slowed down practice-wise, and I'm just super grateful to him for agreeing to do this, because I could think of nobody who has more experience in this arena than you. Again, today's format is going to be that Michael will present his talk with the idea that we'll be interactive here, and Ralph will sort of ask for comments from the audience. And so please do jump in the chat or however you'd like, and we'll make this interactive. Without further ado, Ralph, over to you.
Thank you very much, Rohan. It's a pleasure to be here, a privilege. And I'm impressed with the effort that Michael has put into putting this presentation together. So I'll turn it over to him.
Great. Thanks a lot, guys. I'm going to just share my screen really quickly and get this going. Okay, so topic of discussion today is going to be esophagectomy in the era of bariatric surgery and conduit alternatives and modifications. Just one disclosure, which is not relevant to this talk. So today's presentation is going to be, we're going to touch on various topics, all stemming from a case presentation, including the staging of esophageal cancer, various treatment modalities, and again, then getting more specific to considerations in the patient who's previously undergone bariatric surgery and what conduits are available and some overviews of technique. Throughout today's talk, there are going to be a few different ask the audience kind of poll questions. So if you guys actually wouldn't mind just linking this link onto your phone, and this ID will be asked for once you enter this website. There'll be a few interactive questions that'll come up during the conversation today. So I'll just pause for just a second while people get that on their screens. And if you missed the number, it'll be up during the poll questions as well. Okay. So today's talk is based on a 57-year-old female. She had a past medical and surgical history of the laparoscopic gastric gland placed in 2011. She then was diagnosed with Barrett's esophagus a year later. She underwent a bandage sleeve in 2015. She had poor endoscopic surveillance afterwards, but did undergo a repeat EGD in 2021, which showed a focus of adenocarcinoma on a background of Barrett's esophagus. A biopsy was also positive for lymphovascular invasion. So after this endoscopy, sort of like what one would anticipate, she was referred for endoscopic mucosal resection. That confirmed the diagnosis of adenocarcinoma. Focus was only 0.6 centimeters. It was poorly differentiated in M3 layer and was lymphovascular invasion positive. So she was staged by this as a T1A NX-MX. So she was referred to our clinic for further evaluation and workup. And like all patients with esophageal cancer, she obtained cross-sectional imaging. Which, other than some distal esophageal thickening and previous anatomy of sleeve gastrectomy, was fairly unremarkable. PET scan just had SUV uptake in the distal esophagus, which could be related to the previous mucosal resection or the inflammatory response as part of Barrett's esophagus, but there wasn't any FDG avid uptake in any other parts of the body. So anatomic considerations to take into account for this patient. We typically use a esophageal replacement after esophagectomies with the stomach, that blood supply being based off of the right gastroepithelial artery. However, in the patient who has undergone sleeve gastrectomy, that arcade is now obviously no longer in play, and the stomach is being supplied by the right and left gastric arteries. So poses a challenge for reconstructive options for a patient who would need to undergo esophagectomy. So this is kind of our first interactive question here. So how would you proceed with the patient at this point? So again, if you missed the ID number and the link, it's up here in the corner. I'll give it a few more seconds. Okay.
Michael, before going on, could we, and after we look at these results, could we just maybe ask for some comments on the choice that people have made and the rationale behind it? Because this is not a slam dunk decision.
Sure. So we can pause for that now if you like, or I was going to next sort of discuss each of these points and pros and cons.
Please proceed.
Okay. So good, nice little variety here. So staging of adenocarcinoma of the esophagus. So this patient technically is a T1A patient, for which recommendation is to undergo endoscopic therapy, but also possibly with esophagectomy, with some consideration. Now, naturally, this patient has also difficult conduit reconstruction, so some people maybe could also make the argument that this is a patient who is not a candidate for traditional surgical approaches, and from that inability to maybe tolerate surgery from a technical aspect, should undergo definitive chemoradiation. So we're just going to talk about each of these. So first, are specimens reliable on endoscopic mucosal resection? Now, most of the data in this field comes from looking at T1B lesions. However, this study looked at 85 patients, all of which previously were T1B, and some of them actually were downstage to T1A after multiple pathologists looked at them. They did have overall agreement pretty uniformly if there was lymphovascular invasion present. They agreed about 80% of the time on the degree of differentiation of the lesion. However, they did significantly disagree with the depth of invasion, mostly coming into play with how deep within the submucosa these T1B lesions are, but also with T1A possibly being SM1 T1B lesions. So we can trust our pathologists, but we have to take a little bit with a grain of salt, depending on what layer exactly was being identified on our specimens. So can we observe these patients? So this was a study of 1,000 patients who underwent observation for T1A lesions. About 140 of them ended up having metachronous lesions. 12 patients with T1A had lymphovascular invasion. All 12 of them were referred for surgery. Only 8 of them underwent surgery, and 2 of them were found to have lymph node positivity. Failure rate obviously was of these patients for endoscopic therapy was associated with degree of differentiation. So this is obviously what we're concerned about with these patients. We have a lesion out, but what is the propensity for metastatic adenopathy in the T1A patient? And this was a patient study back from USC from Tom DeMeester's group, which looked at 120 some patients who underwent esophagectomy for T1 lesions. And what was they retrospectively looked at these samples and asked what was the lymph node metastasis rate and what were the factors that led to lymph node positivity. And on the patients who meet our patient, who that I being said were T1A and had lymphovascular invasion, there were 6 patients, and only one of them in this series had positive lymph nodes on specimen. But what about other factors such as poor differentiation and other LVIs and other risk factors? So this is an analysis of the NCDB from 2004 to 2014. They looked at just under 800 esophagectomy specimens. We can see that in the T1A patients, that most of the risk factors for lymph node positivity came with poor differentiation and lesion size greater than 2 centimeters. This study didn't show any patients with T1A with LVI who had lymph nodes, but granted that may be due to sample size, since there were only very few patients who were in fact T1A. So what about definitive chemo and radiation therapy? So most of the data for the definitive chemo RT that's published comes from squamous cell carcinoma of the esophagus rather than adenocarcinoma. So a lot of our data for adeno is extrapolated from our experience with squamous cell. And this is just an example of a systemic review of patients who were stage 1, who were treated either with chemotherapy or surgery. And most of the overall survival in this meta-analysis favors the patients who were treated with upfront surgery rather than with definitive chemo RT. Again, just another study, again, this time, however, looking at patients who underwent surgery or chemo RT, but after already underwent endoscopic mucosal resection. Again, most of these patients are squamous cell carcinoma rather than adeno. However, a 5-year overall survival was more beneficial with patients who underwent surgical therapy rather than definitive chemo RT. As far as our patient in particular, there was really only one study that demonstrated any significant amount of adenocarcinoma patients with T1 lesions. However, this is a retrospective study out of just over 6,000 patients who were treated in Korea in the mid-2000s. Of all of these patients, obviously T1A patients had the best overall survival, but only 36 of them were in fact T1A. So the sample size that was used in this large cohort is still relatively small. So the overall point is that we have very little published on the treatment of a high-risk T1A patient with adenocarcinoma. Most of that experience is borrowed from T1B adenocarcinoma and high-risk T1A lesions in the patient with squamous cell disease. So then what could potentially be our surgical options? Well, there's really only 3 patients that are thus far been described in the literature who have undergone sleeve gastrectomy previously, who were then diagnosed with carcinoma of the esophagus. One patient underwent distal esophagectomy with Ivor-Lewis anastomosis, with the actual stomach being anastomosed up into the chest. Another patient who had a Siewert-3 lesion underwent distal esophagectomy with the Rohan-Y esophagojejunostomy reconstruction. And a third patient with a Siewert-3 lesion who underwent esophagectomy with a colon interposition graft. So this is another point that has to be brought up, obviously, is how much of the esophagus needs to be taken out in a T1A patient. Well, really a lot of it gets based on what is the spread of metastatic adenopathy in upper, middle, and lower esophageal patients. And even in patients with lower esophageal carcinoma, there can still be up to about a 5% rate of cervical lymph node positivity. So that really goes to speak that there should be clearance of the entire esophagus, one for lymph node harvest, but also you can get into the argument of, do you want to have your anastomosis in the neck? If you would leak, it's easy to control, whereas a leak into the chest is obviously much more difficult to manage. So again, the anatomy considerations that need to be taken into account. How can we reconstruct the esophagus in a patient whose vascular supply is diminished? So we have several choices of conduit in this patient. Typically we like to use the stomach. It has a robust blood supply. It's anatomically straightforward. It's one anastomosis. small bowel jejunum is available. It's readily available. It's very good replacement for the distal esophagus, but can have difficulty reaching up into the high neck, and a lot of times requires microvascular anastomosis or supercharging to the carotid and the jugular vein. Colon is nice, it's readily available, can reach up to the neck. Both the right or left colon can be used, but obviously patients who have intrinsic colonic disease or mesenteric vascular disease, this can be an issue. And then we have other salvage options such as myocutaneous graft that is very seldom used and only in a very desperate reconstruction type scenario. So most of conduit alternatives for esophagectomy comes from literature from achalasia. And that's usually because these patients with achalasia have already undergone 1, maybe 2 Heller myotomies. The fundus doesn't have very good integrity anymore, and the blood supply to the greater curvature of the stomach can be questionable depending on the previous degrees of gastric mobilization that have been done. So in these cases, a lot of them will undergo esophageal replacement with colon, while some centers will choose to use small bowel instead. So I just wanted to sort of get an idea of what the audience's experiences with conduit alternatives. So if you guys wouldn't mind with the next question. Just another few seconds. Okay, good. So as I was saying before, one potential reconstructive option is with small bowel. Like I said, it has very good reach for distal esophagus when performing a distal esophagectomy with esophagojejunostomy reconstruction, but has more difficulty reaching up into the high neck, especially when trying to perform cervical anastomosis. If small segments of the esophagus need to be replaced, however, free grafts can be used, but obviously requires vascular reconstruction as well, with transposition of that organ up into the neck. Myocutaneous graft can be used in the salvage of a patient, but this is usually on someone who cannot go under different types of conduit reconstruction because of intrinsic colonic or small bowel disease. This type of technique is very painstaking, has a very high morbidity, and is really only appropriate in salvage cases. And some people also may not even think that such an extensive operation like this is even appropriate to do, and esophagostomy and enteral feeding access by a tube feeding might be more appropriate for a patient long-term, considering the potential comorbidities with this type of procedure. So what about colon interposition? So Dr. Ray, I'm not sure if we want to sort of pause here and sort of get some people's input on how they would pre-op a patient for interposition assessment.
Yeah, thank you, Michael. Really nicely done. Very thoughtful, and you found some literature that's not easy to get a hold of. I think what maybe would be a good place as a starting point for this particular patient, 2 things we don't know about. One is, what is their comorbidity status? What's their operative risk? And I'm asking that because obviously this isn't straightforward, and we'd like to do always the most effective but least morbid procedure. And then secondly, with regard to a patient who's had 2 GE junction procedures, they're having obviously significant reflux. They have Barrett's esophagus. How are they doing clinically? Is this an esophagus that's worth trying to save? We already have concern for Barrett's and possible Barrett's recurrence with stomach anastomosis. And so could you tell us a little more about that?
Yeah, so this patient in particular that we were referring to has very good functional status. She works, she's independent. Other than mild obesity, she doesn't have any other major medical comorbidities. Her previous surgical history was limited to the previously mentioned. So she could potentially be a relatively speaking, low risk candidate for an interposition replacement.
And then what about her reflux control? Is she aspirating at night? Has she got terrible dysmotility and bad dysphagia, or is she doing well?
No, other than her symptomatic reflux, she was doing okay. She wasn't complaining of any types of dysphagia or dealing with food getting stuck and food back up. She was probably having some degree of nighttime regurgitation, because obviously it prompted endoscopic evaluation on her part.
So you alluded to the lymph node issue, and that's really the heart of this discussion, isn't it? Because local disease can be controlled for the most part. There's always a concern that local recurrence will lead to lymph node metastases, but for the most part, with ablation, with recurrent surveillance, extended EMRs, et cetera, the local disease is not the big issue. The question is the concern you've raised for lymph node metastases. So you've done a nice job pulling out the limited literature that's available there for this particular scenario with some high-risk features. But I'd like to ask the attendees how that guides your decision-making here. Is this somebody you would be comfortable relatively comfortable following local treatment relative to the morbidity of doing a major resection? Dr. Jurel's already mentioned definitive radiation chemotherapy. Most of those comparisons are hampered by the fact that the non-surgical group tends to be sicker and not as ideal candidates, so their survival overall tends not to be as good. We don't have any really good head-to-head comparisons for early disease like you were talking about. But I'd really like to ask the attendees here, what do you think about the histologic features here, and would you consider a more conservative approach?
So Ralph, let me ask Dr. Rosato if you can comment, Francis. I'd love to hear your perspective from Jefferson on how you would approach this if you're available for comment.
Sure, I'd be happy to comment. You know, with a T1A lesion like this, you know, I would fully evaluate this patient with pulmonary function test, cardiac evaluation, before I would jump into an operation, because the morbidity from it is not insignificant. You know, I think you did a good job pointing out the information regarding the risk factors for lymph node metastases. But, you know, I do not see anything that was presented that would suggest the patient is not a surgical candidate at this time.
Ralph, thank you, Francis. Ralph?
Thinking about the location of the tumor also affects the extent of the operation. And Michael already commented and showed some statistics on lymph node metastases, but there were several cases that were presented there with CWRT1 and CWRT3, which really are GE junction to gastric, bordering on gastric tumors. So for a patient like this who still has sleeve anatomy intact, what would you do if the tumor were at the GE junction instead of at 34 centimeters?
So
that would be a completion gastrectomy.
Yeah. So so you would approach that from the abdomen, Dr. Rosato?
Absolutely. And I'd go as high as I could. And if I couldn't get a negative margin, I'd you know, bring up small bowel until I did through the left chest.
Yeah. Dr. Benzie, do you have any comments for Dr. A?
No, I think I agree with that. I would do a completion gastrectomy as well. Obviously, you know, send frozens and get as much as you can. But I think in a T1A patient, you know, on EUS, she has no findings of obvious lymph nodes, even though she has high-risk features. I would, give the option of, short-term surveillance first, because, any kind of alternate conduit or even EJ is definitely a high risk.
Yeah, no, that's a great point. I think, Ralph, for me, it was really surprising to see the data that he pulled on poorly differentiated lesions. And I think if I remember right, this was a poorly diff lesion, right, Michael?
Yes.
Shlomi, you will do quite a bit of esophagus at your location, Dr. Raymond. Could you comment, Shlomi? If you're there. Or James Kurtz?
Yeah, I think I kind of agree with the comments that have been stated here so far. I don't really have much else to add from what I heard.
Back to you, Ralph.
So in terms of replacement, those of you who have used small bowel limb and brought it up into the mediastinum, how high do you think you can reasonably come with that? Would that have been an option in this case at 34 centimeters?
Dr. Kutlu, are you on? Can you comment? I don't know if you've got audio. Dr. Nasser, are you on?
So Rohan, I can say I think the highest that I've ever brought small bowel has been to the carina, and that was a dicey case, and that was a patient with good anatomy. And so generally, I think it's hard to get much beyond the sort of lower mediastinum. Would you?
I would totally agree. I was just thinking about what Dr. Rosato said. So I was always trained to go in the left chest for these GE junction cancers, Ralph, and I hate doing that now. I actually like to cut the central diaphragmatic tendon and get as high as I can with, if I'm open with the retractor behind the heart. And I can usually get, as you said, to about the level of the carina. It's always dicey, as you said correctly. Thank God for staplers.
So what about the option that was discussed in, I think, one of those examples? Let's say you had a Siewert 1, which is at the upper end of the GE junction or distal esophagus, and you have sleeve in place. You can take the proximal sleeve and get the arcade, the left gastric vessels and associated lymph nodes, which are really a critical part of that operation oncologically, and still have some sleeve to work with in terms of bringing that up. I have not had any personal experience, but I wonder if anyone could comment on that. If you brought distal sleeve up for partial reconstruction of the esophagus.
Wait, Dr. Chow, you do sleeves quite a bit. In my experience, that right gastric cloaca, usually, if it's done correctly, it's pretty much gone, right, Dr. Chow?
The right, well, we're supposed to stay at least 4 to 6 centimeter. At least that's the recommended distance from the pylorus. And to be honest, I think a lot of times we really can't tell. But then again, if you think about, if you do a pull-up, the right gastric cloaca is supposed to feed the greater curvature, right? I think it would be good if people actually try to just use a sleeve and just pull it up and see if it works. I mean, Michael just cited one case where it worked and the patient has stenosis, but that just, whatever blood supply is left on the sleeve might be enough for the sleeve because you're not necessarily feeding a whole stomach anymore. As far as actually, we always tell the patient when they have Barrett's that we recommend a gastric bypass because it would preserve the lower blood vessels if they should ever need a pull-up operation. But I think it would be good if someone actually did more of these cases with just the sleeve, because remember, the right gastric cloaca is really feeding the greater curvature, right? And with the sleeve stomach, the greater curvature is actually gone. And I think there are just not enough data to say, hey, is this doable? But I think if people tried it, it might be.
So I think, Dr. In, do you want to comment? Because I think for me, Ralph, the chest pain aspect is that if it doesn't work, it's a disaster, right? That's the issue.
Right.
But do you think, Francis Rosata, that in a case like this, if you got an angiogram and you saw sort of, 5 centimeters of the right gastroploic, that would change how you would approach this, or would you still go to something different, Francis? I don't know if he's dropped off, but for you, Ralph, would that?
Well, there's another consideration, which is with typical gastric pull-ups, there is a rate of Barrett's developing in the minimal residual esophagus because of continued acid and bile. And in this case, if you brought the distal sleeve up and patient already has Barrett's, you could argue that that would be another reason not to do it, although the parietal cells are pretty much gone. So that may not be an issue, but generally it seems like a RU would be a better option. You have more control over the procedure, and oncologically, you're not worried about compromising the blood supply to the sleeve by taking those left gastric vessels. So I would agree with you that you're kind of boxing yourself into a corner a little bit.
Should we go on, Ralph?
Yeah, so thank you, Michael. So you brought us to, first of all, the decision to do a resection in this case, primarily because of the concern for lymph node metastases. And I think that was, again, I'd echo Dr. Jeyarajah's comment that you did a nice job pulling out some literature that I really wasn't totally familiar with in terms of the risk of lymph node metastases with LVI and with poor differentiation. So not all superficial lesions are the same. So once the decision's been made for resection, primarily for an oncologic standpoint, and you have a tumor that's at 34 centimeters, sort of mid to distal esophagus, you're probably looking at having to get how much of a margin above that? Did you find some literature on that, Michael?
I mean, margin, you're getting anywhere between 5 to 10 centimeters, so you're aiming for that really realistically, that 5 to 8 centimeter type of range. And obviously you're going to have anatomic constraints depending on the location of the lesion within the esophagus.
Yeah, so now you're up to the azagus and or above, and so some of those other options are not good ones. So do you want to take us through your thoughts about colon interposition?
Yeah. So as far as assessment goes, other than the traditional preoperative assessment for a high-risk procedure, for this in particular, obviously we're going to get cross-sectional imaging, as we've already have. A dynamic angiogram is also very useful. And what we're looking for here is to get a good sense of what the colonic blood supply is and how it communicates throughout the entire colonic arcade. Obviously, we need a colonoscopy. We need to clear the colon of any high-risk polyps, any history of diverticular disease, angiodysplasia, or any other intrinsic colonic disease. It goes without saying that any patient with ulcerative colitis or Crohn's disease would not be a candidate for colon interposition. And then what side of the colon do we use? Do we use the left? Do we use the transverse? Do we use the right colon? And there's literature to support all of these different conduit choices, but really it comes down to what is the vascular anatomy of that patient in particular. In general, there are several different types of arrangements of colonic blood supply. So knowing what your patient has is really going to be the best. And again, sometimes a dynamic angiogram is really going to be your go-to rather than CTA. So what do we use? So if we're going to use the left colon as our conduit, that's mainly going to be based, its arterial supply off of the IMA. The left side compared to the right is a slimmer conduit, so it's more quote unquote similar to the esophagus in that sense. You potentially have more length because you're bringing up part of the sigmoid colon as well. And obviously that's going to depend patient to patient, depending on the patient's individual redundancies. With the left colon, however, you do need to take the IMA into consideration because that's going to be your main venous drainage. So if you have a patient who's had a previous splenectomy or a previous distal pancreatectomy, previous severe pancreatitis, who has splenic vein thrombosis, your IMA might be out. In this case, your venous drainage would be compromised. So you might be able to physically bring that left colon up into the chest, but that conduit is going to necrose because of venous outflow obstruction. The right colon is typically going to be based off of arterial supply from the middle colic and from the arch of Riola end. It's going to be a slightly wider conduit than the left. The right colon, however, also has a little bit more variability, as shown on the previous slide, in terms of its arterial anatomy. So some people may be uncomfortable with those different variations. Obviously, using a left colon based on the IMA, that can be problematic in a patient who has mesenteric atherosclerosis, because we know that the IMA is typically the first targeted blood vessel of mesenteric atherosclerotic disease. So if we are going to use the left colon, how are we going to do that? Well, we're going to bring the patient in, we're going to medialize the left colon and the splenic flexure, identify the IMA and the middle colic. We're going to ensure also that the arc of Rioland is intact. Obviously, if we know on preoperative imaging, if we have any other aberrant anatomy, such as arc of Moskowitz or a marginal artery of Drummond, or sorry, or a meandering artery, using the left colon is going to be very difficult and potentially even contraindicated. But we're going to bring the colon up. We're going to identify its anatomy. We're going to divide at the level of the base of the middle colic, transect our colon. We're going to ensure that it has proper blood supply, and that can be used either by a Doppler or fluorescence types of imaging in the operating room. In this case of transposition, the colon can be fashioned in an isoperistaltic orientation, so that the MMC complexes are able to be maintained to some extent. Of important consideration, a lot of these patients who are going under interposition replacement may not be having primary surgery. A lot of these patients are going under interposition because of previous conduit necrosis or caustic ingestion with esophageal and gastric necrosis. So the posterior mediastinum is not an available route. And a lot of these patients will undergo transposition using the anterior mediastinum or a substernal tunnel. And in that case, it's appropriate to resect part of the sternal manubrium. One, because it's a potentially luminal obstructing point, but can also pinch off the vascular supply, particularly the venous drainage in this area. So an important consideration to take when taking that route. And then we also have the right colon can be transposed up. This technique was described by First, and is usually going to be based off of the left branch, the middle colic artery, as well as the IMA from the arc of Rioland. And we're going to medialize the right colon and hepatic flexure, ligate the right colic artery, plus or minus ligation of the right branch of the middle colic artery, depending on its exact orientation and the length of colon that's going to be needed. We're going to obviously reassure its blood supply. Please do an appendectomy if the cecum is what's being brought up into the neck. Some people will choose to anastomose cecum or the proximal ascending colon directly to the cervical esophagus, while some people like to anastomose terminal ileum. Pros and cons to that: obviously, the terminal ileum is much more similar in caliber to the proximal esophagus, and some people think that having the ileocecal valve in place is potentially an anti-reflux barrier if the stomach is still going to be intact in the abdomen. However, people who don't like to do that do claim that the ileocecal valve can be a potentially obstructing point from a standpoint of PO intake and dysphagia. So in the patient previously presented, how would you guys all choose to reconstruct this patient if faced with that scenario?
So those on the call, please look at this website that Michael has put up. It's really, really easy. We'd love as many participants as possible.
Sorry. Okay, so most of the response like the right colon. And that's exactly what we did with this, with the patient presented. So we used the technique as described in the previous slide, and the patient underwent a uneventful open right colon interposition graft with esophagectomy. And on postoperative day 5, we obtained this upper GI fluoroscopy study, which showed the right colon conduit in the chest without any anastomotic leak.
Michael, could I just challenge those who were doing pull-ups of
Sure.
either Roux-Y or sleeve pull-up, what your thoughts are in terms of margins? And I'm asking that not in so much a challenging way, because I think this case is a little different. You know, the historic data I think came out of Hong Kong showing you need at least 8 to 10 centimeters of proximal margin on an esophagectomy for esophageal cancer. And that was based on studies done looking at the submucosal lymphatics and how abundant they are and how much we can be fooled by thinking we've got above it. But this is a case where, you know, it's still limited local disease, and the margins were clear on your EMR. The depth is, I believe the depth, the deep margin was negative in this case. So I just want to, is there anyone who's willing to comment on your thought about Roux-Y or esophagectomy, and how high, or pull up, how high would you be going with your anastomosis with a tumor that's at 34 centimeters? What do you think is an adequate margin in this case?
Anyone want to comment that gave any of the choices with the sleeve or with the Roux-limb? Just explain their thinking and how they might do that. Dr. Nasser, do you want to comment on your question in the chat too? Maybe not. Okay. So I think, Annie, do you want to sort of talk about this and give us your thoughts?
Sure. So the only just caveat to this, the only thing I've ever done is a right colon interposition, so I don't have experience with anything else. However, it is relatively straightforward. In terms of getting preoperative assessment, I agree at least a CTA, and part of it is because the patients that have esophageal cancer also are usually vasculopaths, so you really need to make sure that you have good blood supply. The other thing too, I think would be very helpful is use of intraoperative ICG. So we have SPY, or we had SPY at Methodist Richardson, but you can also use a laparoscopic striker camera if you don't have that technology and just turn off the lights. It works exactly the same way. And then, like I said in the chat too, I actually did an appendectomy in the neck. I didn't think I would ever do that in my whole life. But in basically Googling how to do a right colon, I found that part out, and I actually did it in real life. I thought that was very helpful. And then just another weird thing that I did during that case was actually take kind of the SPY, like that long plastic tubing, snake it up with the NG first, lube it up, and then bring in the colon conduit up. And that really helps to decrease the friction too. So if you're ever in a bind trying to get that colon into the neck, that technique seemed to be really helpful. Otherwise, I think, you know, if you're comfortable going into the left or right chest, or even taking down the central tendon, I do think from an oncologic perspective, maybe in this case, because we are worried about nodes, maybe that wouldn't be the greatest choice. But if you have a benign disease patient, I think the morbidity of, you know, taking out the colon and flipping it upside down can be considered, and maybe an EJ in a patient with more benign disease would be helpful if you can't use the native conduit.
Great comments, Annie. You know, Ralph, when I did my first colon interposition, I was faculty at UT Southwestern, and Bob McClelland, who took care of JFK when he was brought to the hospital, helped me do that case. And Imran, who's a colorectal surgeon, I begged my colorectal colleagues to help me, but nobody had done it before. So thank God for Dr. McClelland. But it is, as Annie said, you know, it's the right colon especially is a fairly robust conduit. I've only done a few lefts. Ralph, can you comment on the left? It's a little bit more stressful to me, although it's a longer and a nice slim, graft.
Well, I think Michael wants to get into a little more detail about this, but I would say that I think this is a very timely discussion, because colon has been something that, as you said, we hardly ever do. even in a busy esophageal specialty practice, it hasn't come up that much. But clearly, this is going to be more of an issue as time goes on, because the stomach conduit is not always available. So Ronald Belzy is the one that really first developed all the technology and the case studies around colon interposition. That was back in the 50s and 60s. He was in Bristol, England, highly respected surgeon by everyone who knew him. And he did a ton of them, because this was really sort of at the time the Japanese were first doing their work on stomach pull-ups. And so colon was the logical conduit. And he argued for left colon because of the size comparison that Michael's alluded to, the fact that it's more used to dealing with solids. It is purported to have a bit more motility even after the interposition. And the blood supply is generally described as being pretty reliable as long as that inferior mesenteric is intact. So that's really the only experience I've had, except for rare occasions, with right colon. But I know there has been a shift toward right colon, and I suspect that it's one thing about that makes the left colon a bit more challenging. If you do a formal left colon interposition, you really have to mobilize the sigmoid colon. So attention to those vessels, preserving the ascending branch of the left colic, taking the more distal branches is part of that thought process, that technology, the details, the critical aspect of that operation. So you can definitely screw it up at that location. And then the marginal artery, of course, has to be intact. You generally don't even need to go very far across the transverse colon if you mobilize the sigmoid colon in that way. You can use as your anastomosis the distal transverse colon, or somewhere at the point of the middle colic. And before I forget, let's not forget that there is a long history of using short colon interpositions, especially for benign disease, if you only need to come up to mid-chest. And so I think that might have been an option in this case, if you only wanted to come up to, say, the azygos. So that's an easier procedure to do. You could do the whole thing based on the middle colic artery, for example. Right colon, the disadvantages that have always been mentioned around it are the size discrepancy, the fact that it deals primarily with sort of liquids, and there's a lot of sort of to and fro churning motion in the right colon, as opposed to the peristalsis of the left colon, the blood supply being a little less predictable, as Michael's already alluded to. But I suspect that it's quite a bit more straightforward, because you don't have to get into all that mobilization of the left colon, and you just bring it up, divide the middle colic artery, and bring the ascending colon up, and it's pretty more straightforward. But I'd like comments from those of you who are, why the shift toward right colon? That's not been and the literature search I did just before this conference, the preponderance of data still seem to favor left colon, and yet I don't think that's what's happened, as we can see from this survey and some of the comments that have been made.
Yeah. So Ralph, can we hold that thought and let Michael finish this? And then I'd love Sharon or Ross, and she joined, to comment. But Michael, why don't you whiz through what you've got and leave us about 5 minutes for discussion. So you've got
Sure.
6 minutes, Michael.
So like I said, this patient underwent right colon interposition as previously described, their fluoroscopy study on day 5. So that's standard for our esophagectomies. Day 5, they get an upper GI swallow study. If they pass that, their nasogastric tube is removed. They undergo an additional first evaluation with speech therapy for swallowing function. We'll cycle their jejunostomy tube feeds at night and discharge home diet with goal of mechanical soft. And this patient left the hospital after 10 days in-house. Her final pathology didn't show any residual disease, just background Barrett's esophagus with 23 negative lymph nodes. So her final staging was based off of her EMR specimen. And sort of like we were about to get into discussion of, I think, colon interposition graft obviously is not a benign procedure and has a leak rate, at least in this series, of about 14%, and really has a big effect on the 5-year overall survival. A patient who leaks is going to have about a 5-year overall survival of about 33%, whereas if they don't leak, that rate is just about doubled. and likewise with lymph node positivity or negativity. And as we alluded to at the beginning of the talk, the rise of morbid obesity is very, very real. And with that rise goes the increase in bariatric procedures, which according to the International Federation for Surgery of Obesity and Metabolic Disease, in the year 2019, there were over 800,000 bariatric operations registered worldwide. And that definitely doesn't actually cover the entire world, but just about, at least at that time, about 50 nations. But over the last decade, bariatric procedures has been on an exponential rise. And then goes with what are the potential consequences of that? Well, obviously esophagitis and GERD in the patient who's previously underwent a sleeve gastrectomy is a fairly controversial topic with a lot of opinions in both ways. Was the GERD present beforehand or afterwards? The problem is that a lot of these patients who do, in fact, develop esophagitis after sleeve, or who do develop Barrett's, do not have symptoms. So they don't know to refer themselves to a gastroenterologist. They don't know that they should undergo endoscopy. And at least as of right now in the United States, endoscopy, upper GI endoscopy is not a requirement for primary bariatric procedures. It is recommended for revisional operations, and it is recommended in Europe and in other countries, but at least right now in the US, EGD is not mandated for primary bariatric operations. So in a lot of that sense, we might not know what the true rate of primary Barrett's is on these patients beforehand, because a lot of these obese patients will have asymptomatic esophagitis and will have asymptomatic Barrett's esophagus. And likewise with bariatric surgery, at least in the West, esophageal cancer is also on the rise. And with both of these going hand in hand, like Dr. A had alluded to, there's only going to be a rise in this cohort of patients who are going to require esophagectomy who've already had bariatric procedure. And just a few other things to take into consideration. There's the bypass patient as well. Typically here, the gastroepiploic arcade is going to be intact, but in some surgeons who do an anti-colic technique, they will cut the greater omentum just to put tension off of the rumen. And if that incision is a little bit too generous, the gastroepiploic arcade can sometimes be sacrificed. But a nice technique for esophagectomy in this patient is just to use that, involve that gastric pouch and the proximal roux limb in your specimen, mobilize the excluded stomach, and then the remaining roux limb can be used as a entrance point for your jejunostomy tube. Obviously, other patients like those with vertical banded gastroplasties are becoming fewer and fewer, but there are still patients obviously who have bands, and there are patients likewise with similar anatomical considerations who have undergone previous fundoplications, where the integrity of the stomach might not be as robust as a non-operated stomach. We don't necessarily know what the vascular supply or the integrity is of the fundus, so a lot of these patients might need to have consideration for conduit alternatives as well. And as we alluded to, that this is going to be becoming more and more common. We have another patient who is in our pipeline who has a history of achalasia, who underwent Heller myotomy 20 years ago, who then underwent a sleeve 10 years ago, who has recurrent disease and has been dilated 20 times in the last year, stented twice, and still has about a 5 centimeter distal esophageal stricture. So what to do here? And that's it. Thank you, guys.
So Ralph, do you want to, Sharona's on, so did you have a question for her? She sort of does everything.
Thank you, Sharona. So we were talking about the fact that colon interpositions are likely going to see increasing versatility as we look at more bariatric cases in the future. And I was trained with left colon based on Belzy's experience. That seems to be still the predominant approach in the literature, but there's been a shift toward right colon, and I suspect that it's just technically a little more straightforward. But do you have any comments on right versus left?
You're on mute, Sharona.
Hey, good afternoon. Sorry for being late. I'm still didn't finish clinic yet, but I thought I didn't want to miss this completely, so I apologize. It's funny because I was trained the opposite. I was trained to do the right, to flip the right up into the chest rather than the left. So I think we're all a product of our training in a way. Fortunately, I don't take care of bariatric patients. So I had a discussion with Rohan when he posed this with the sleeve gastrectomy. It's a real problem. You can't use the stomach anymore. And I know many sleeve gastrectomy patients that all have reflux issues, and that's what they complain about. And so it is an issue. I would, and I have done the right colon as rather than the left, but I think it's more of what you are trained and therefore feel more comfortable doing rather than what would work. I don't think there's a problem with bringing the left. It's just that I felt more comfortable using the right.
Thank you. Two more comments about colon. One is bulldog clamps are your best friend when you're strategizing the exact vascularity of that particular patient and trying to determine what segment to bring up and how the blood supply is. Put bulldogs across the vessels that you plan to sacrifice and make sure your conduit remains viable, bring out the Doppler and check your signals and so forth. And then secondly, we always do measurements. I don't know that it's critically important to do that, but determine how far up you're bringing the conduit and then measure from that point toward your insertion site down below and make sure you'll have enough length relative to the shortest length of your limiting arcade. And then a comment too about cervical versus intrathoracic anastomosis. There are a lot of advantages to a cervical anastomosis, and in particular, prior to covered stents, the lethality from an intrathoracic leak was really high. With covered stents, we've been able to salvage a lot of those. So as you probably all know, there's been a shift toward doing more sort of Ivor-Lewis approach with gastric pull-ups, and that could hold for colon interposition as well. But again, as Sharona said, I think it depends on your comfort level, how you're trained, and what you're used to doing. The critical thing with esophagectomy is try to get it as standardized as you can, because it's such a high-risk procedure. There's so many steps, and the more you can standardize, the more you can do it the same way every time to get that reliability, the safer an operation you'll have.
Well, one comment, I would add ICG for any technology that can be helpful for blood supply for the conduit you're going to bring. That might be useful. And I think we see more Ivor-Lewis because more thoracic surgeons kind of adopted the esophagectomies rather than general surgeons who are maybe not necessarily trained in the chest, that are more likely to do transhiatal. I do all mine transhiatals. I rarely have to do the 3-field, where usually it will be a squamous cell that I'm worried about the arch and that involvement in the area of cancer. Otherwise, I would do everything transhiatal and bring the esophagus and the proximal stomach to the abdomen outside in, and then bring the stomach up into the neck while suture. So in other words, I bring in the NG tube down through the posterior mediastinum, suture it to the conduit, and then pull on the NG tube from the neck and bring in nicely the conduit with lots of lubrication to easily into the neck and do the anastomosis, which usually is with a GIA stapler, and then suturing the common anerotomy. So it can be done either way, but I think we see more thoracic because more thoracic surgeons are adopted it, and therefore a lot of Ivor-Lewis.
A good point. And Rohan, I was impressed with your lymph node harvest in this case, and you're going robotically transhiatal, I believe. And could you comment on your dissection in the middle mediastinum?
Yeah, so actually this case, I believe we did open, right, Michael? I think we did open because I was too stressed with the, but this is true of our robotic cases. We actually looked at this, Ralph. We looked at our 3-field surgery in the McEwen thoracoscopic abdomen and neck, all MIS, compared to our transhiatal. And we actually found no difference in nodal retrieval. We did look at our open compared to robotic. And interestingly, we just published this. This is probably related to patient selection, but our R0 rate was higher in the robotic group, believe it or not. And this has kind of, under multiple analyses with different patient sets, we've come up with the same finding, Ralph. So I do think, we try to stay as far away from the organ as possible to try to take as much fatty tissue as possible, but we sort of cheat, and at the very end, we do a limited hand port, basically, to do that last part bluntly in the neck instead of, and I do the pyloroplasty and coker on the abdomen with the specimen out through a very limited hand port, basically. But we do have to wrap up. This is great, but Ralph, what would you do with this case? Achalasia, multiple 2 Hellers, stents not working, and sleeve.
And the stricture is a reflux stricture, is that right?
We think so, but the problem is the esophagus is not working.
Yeah, and this is a 20-year history of, I recall.
Correct.
So you've got a burned out esophagus. I think this patient will be far happier with a replacement. Take out the esophagus and bring up colon or stomach. Well, you can't bring up stomach, so colon, yeah.
Yeah, it's crazy. Well, thank you everyone for joining today. This has been really wonderful. Michael, thanks for doing a really good job with this. I really appreciate everyone's support of the SSAT and the fellowship programs. We'll be back next month, and thank you for all of you for taking time out of your busy schedule, especially with the holidays having come and some coming. And thank you all so much. We will see you soon. And Ralph A., you, as usual, are a prince.
Take care.
Thanks, everyone.